I'm happy that I could attend at least one in India.
Okay, thank you, sir. Thank you, sir.
Thank you.
One more is there. I think so. It is
Yeah.
almost
But anyhow, I
Mahavir.
attended your platform earlier, so I thought
Okay,
I will join. Right, good.
okay, sir. Thank you, sir. Thank you very much, sir.
Sir, we are live. Do you
No,
want me to?
I have to
Yeah,
thank you. Yeah.
yeah.
Good evening, everyone. Myself, Dr. Shilpa Nambiar, on behalf of Raigad IAP, welcome you all to this another very interesting and interactive session on the occasion of World Autism Day. Our theme being Empowering Autistic Voices. Autism Awareness Day was actually started by the United Nations to spread awareness in the year 2008. And today we have a great set of program arranged for you with excellent speakers. Before we can start today's talk, I would request our IAP Raigad President Dr. Vikas More to share a few words.
Thank you, Shilpa, for inviting me. First of all, I am very much thankful to Dr. Sandeep Kavade from Pune, who graciously accepted our invitation for this special day and on the 11th hour. And respected Srinivasan sir also joined. Uh, Respected Hemant Gangulia sir had joined, and uh, Gopika madam, with whom I connected during my COVID days, with whom I done a very nice program with a autistic parental society. So I had a very good first-hand experience. So I always believe that seniority comes with experience, not with age. That is my personal experience, because gray hairs doesn't signify the excellence in a particular subject. So your enthusiasm, your a keen interest really signifies the excellence of your field. So the today's theme was, as a pediatrician, I struggle a lot while dealing the autistic kids who want to join the skills, because we know that have a lot of communication barriers, uh, because there's a huge spectrum in the autism kids. They find difficult to understand the instructions, metaphors, and even they don't understand a simple sarcasm also in a school. So it is very difficult to handle such kids. And I was very curious how these special educators do in school. So that was my very interesting. As a pediatrician, I wanted to know that. And there are obviously these all kids. Dr. Kavade has joined today, so we can understand the social challenges being faced by all these autistic kids, by difficulty in making friends, understanding the social manners, engaging in various group activities, and all we know that they have very sensory problems, like they can't actually bear the loud voices sometimes, loud noises, crowded spaces. So lot of problems they face, and especially uh, uh, because I feel that the autistic kid come with a behavioral issue in the parents also, because they think 24 by 7 for the future of their kids, and gradually impacts their own parental health also, like behavioral health also of the parents. So there are so many things in a multidimensional way has to be deal with a autistic kid. So today we're fortunate to have Dr. Neha, Dr. Sandeep Kavade sir, and Ms. Gopika. They will be guiding us, and most importantly, our own Shilpa Nambiar, Dr. Shilpa Nambiar madam, who will be moderating the session, who is herself a developmental pediatrician, and she graciously accepted to moderate the session. And thank you so much, Shilpa, for that. Over to you, Shilpa.
I would also like to invite our AHA, IAP AHA President, Dr. Sunita Ingle ma'am, to say a few words.
Yeah. So, good evening, everyone. Really nice to see this program being conducted in under our AHA and IIP Rider. And I'm sure you all are eager to listen to the experts. So, I welcome all these experts, Dr. Neha, Dr. Sandeep Kavade, Gopika, and Shilpa Nambiar also, and all our viewers who are watching this on YouTube Live and who have joined this program. So with this, hand over to Shilpa. Thank you.
So without wasting any time, I will quickly introduce our experts today. So we have Dr. Neha Singh ma'am. She was the editor of she is currently she's a pediatrician and adolescent consultant practicing in Navi Mumbai. Currently EB member of IAP Raigad and co-chairperson of Maha IAP organizing committee and scientific committee. She's also been editor of Spandan, Drishtikshep, and other bulletins involved in IAP. Our second speaker, Dr. Sandeep Kavade. Sir is child and adolescent consultant, director at Vatsalya Mother and Child Care, Bosari, and director of Manmoy Child Development Center. Sir is faculty of Life Skill Education Program, AACCI. And our third expert, who is Miss Gopika Hosangadi. She is a remedial educator and closely works with students of special needs in the age group of 3 to 8 years and has helped them to have an inclusive school setup. So we'll quickly go with Dr. Neha. Ma'am, can you please start your slides?
Thank you, Shilpa. So I would like to thank IP Raigad and EHA Raigad for giving me this opportunity. And I would also like to thank Dr. Vikas More sir and Dr. Sunita Ingle ma'am for giving me this opportunity. So friends, World Autism Awareness Day, which is celebrated on 2nd April each year, the puzzle pattern reflects the complexity of the autism spectrum. Logo adopted in 1999 as the universal sign of autism awareness. The different colors and shape represent the diversity of the people and the families living with the condition. So autism spectrum disorder is a neurobehavioral condition with onset in early childhood with core deficit in 2 domains, impairment in social communication or interaction, and restricted and repetitive behaviors. Spectrum in ASD indicate that each individual is affected in different ways with mild to severe symptoms, often with overlapping comorbidities. So according to Indian Journal of Pediatrics 2021, estimated prevalence is 1 in 68 children, 3 times more common in boys. ASD is seen in all social classes as well as all countries. So what are the etiopathogenesis? It can be genetic, prenatal factors and perinatal factors. So let's check first the genetic factors. The first degree relative of ASD patient more likely to be affected, and there is increased rate of ASD in siblings of an index child and very high in families with 2 or more children with ASD. In twins, monozygotic pairs are more affected. ASD is found to have syndromic association with Fragile X syndrome, Down syndrome, Angelman syndrome, while the prenatal factors, advanced maternal and paternal age, maternal gestational bleeding, gestational diabetes, maternal obesity, intrauterine infections like CMV, rubella, and short interval from prior pregnancy are the main prenatal factors, while the perinatals are birth trauma, fetal distress, LBW, low Apgar score, congenital malformation, hyperbilirubinemia, ABO, or RH factor incompatibility. So the most postmortem and neuroimaging is suggestive of involvement of cortical as well as limbic system, decrease in the number of Purkinje fiber or granule cells in the cerebellum. While these factors indicate that there is prenatal origin. Currently, there is no diagnostic marker of ASD, but diagnosis requires proper history and direct observation of the child's behavior. And we have to look for the diagnostic criteria according to the DSM-5. So let's see the early signs of ASD, which are for 18 months and above. So we can see in the flyer from chapter of Neurodevelopmental of Pediatrics of IAP, ASD affects 3 critical areas of development: social, communication, and cognitive. So the 7 signs to be looked are: child does not look towards the pointing direction. They may not comprehend the joy of sharing, may not follow the actions or gestures shown to them, does not smile back or smile very less, may make no direct eye contact, does not respond to calling of name, and uncomfortable when kissed or hugged, do not play or mingle with other kids, prefer being alone. While the late signs are from 36 months and above, and here we can see 10 signs are to be noted. Child tend to spend more time alone, does not interact or play with other kids, does not respond to call and appears deaf, uses adult hand to indicate desired object without any interaction, avoids eye contact with the people interacting with them. The child may appear to be attached to certain toys or objects and would not share these objects with other people. They exhibit unusual behavior like rocking, twisting, hand flapping, toe walking, prefer not to be hugged or touched by people. Playing is often solitary and not creative, may not respond to normal or conventional teaching methods, but can showcase certain peculiar activities or skills like music, art, puzzle, solving, etc. So according to the severity, level 1 are those who use proper sentence but not able to reply back, so they require support. Level 2 are those who not able to use complete sentence, but they use simple phrases, so they require substantial support. While the level 3s are those who are not able to use even simple phrases, but speak only isolated word, so they require severe or very substantial support. Few difficulties or issues in autistic kids are like social issues, communication issues, repetitive behaviors, bizarre behaviors, motor issues, also sensory issues, self-injury behavior intention is there, safety issues, comorbidities, and we have to look after the red flag signs. So let's first check the social issues. So they have very little interest in human face. That is, there is disturbance in the development of joint attention, attachment, and other aspects of social interaction. Often developmental progression is seen in older or more advanced individuals who are willing to accept interaction. Autism is generally a lifelong disabilities. So here we can see the comorbidities that they show no interest in other children playing, maybe vicious with siblings, have no interest in peekaboo and other interactive games, strongly resist kissing or hugging. Communications issues are like unaware of environment, avoid eye contact, hand leading. While the verbal communication is very poor, 30 to 40% of individuals with autism never use language for communication. Delay in speech is the most frequent presentation or complaint of the parents, like echolalia, pronoun reversal, non-reciprocal speech, and intonation in monotonic or robot-like speech. Repetitive behavior is seen, like flapping of hands, spinning, swing, and lining up of toy cars, rocking, bizarre behaviors we can see, they can have like staring off ceiling fan, picking lint in the sunlight, may not play appropriately with toys, but they are more interested with the movement of the wheel of the toy or any other toy. So they have obsessive switching lights on and off, unusual eating objects like habits like clothes, mattresses, curtains, napkins, flickering fingers in front of eyes, find ways to get heavy impact to their body. While the motor issues we can see, there is deficit in fine motor, poor coordination, deficit in depth perception, balance issue, drooling of saliva. While sensory issues we can see, they have parents may face extreme difficulty while haircuts, unable to tolerate seat belt, may be almost impossible to bath them, gags at common indoor-outdoor smells, may have difficult tolerating music, but they sometimes appear deaf even to loud sounds, but at sometimes hearing seems normal. So spinning other movement disorders are like spinning objects close to the hand, resisting having changing of clothes, may rip off their own clothes, labels and seams. Self-injury behavior they may show like head banging, self-biting, ripping and scratching of skin, pulling of their hair. Safety issues which we have to be carefully looked after because they have no sense of danger and they does not recognize situation where they may get hurt. They also have no fear of height. Other comorbidities are intellectual with disability, epilepsy, immune dysfunction, sleep disturbances, GI disturbances like diarrhea, constipation, undigested food in stool. They have severe self-limiting diet and or food sensitivity. They also have altered pain responses or diminished absent pain responses. They have also most common comorbidity is seizure, which increases with age without any unknown etiology. So as a pediatrician, what is our role? Our role is early suspicion and screening using M-chart, counseling of the parents, and appropriate referral to a developmental pediatrician, regular monitoring to note the improvement of the child from time to time. And what is our aim? Helping the early diagnosis of children with red flags, helping parents already aware of the diagnosing towards the appropriate intervention, and helping parents to understand and be hopeful about their future. So these are the red flags for ASD, like poor response to name, call by 1 year of age, no meaningful words by 18 months of age, does not play with toys appropriately, fixed pattern of interest or activity, decreased interest in peers or friends, has odd movement pattern or very repetitive behaviors, demonstrate echolalia, that is repetition of words. They may be very shy or very hyperactive. Toe walking may be found. So here we can find many scales which are freely available on internet. But as a pediatrician and in our daily OPD, we can do at least modified checklist of autism in toddlers, that is the M-chart. So it is very easily available on internet. There are about 20 questions, very easy questions to be explained or understood. Just the parents need to answer these questions in yes or no. Many languages also available, English, Marathi, Hindi. And if we just as a pediatrician, we have to do the scoring. In all items except 2, 5 and 12, the response should be no. While if the response to 2, 5 and 12 is yes, then that is also indicative of ASD. If the score is 0 to 2, then it is low risk. If the score is 3 to 7, medium risk. And if the score is in between 8 to 20, it is high risk. Always remember, medium risk and high risk kids, ASD kids, we have to refer to the developmental pediatrician. And we have to also remember the differential diagnosis like ADHD, social anxiety, restrictive attachment disorder, OCD. The treatment and the pharmacotherapy will be looked after by the social development pediatrician, and strategies for teaching in children with autistic in a classroom should be looked after proper educators, that is the special educators. So friends, always remember autism is generally a lifelong disability, with most individuals needing significant family and community support. With early intervention, long-term outcome improvements are seen. 15 to 20% are able to achieve independence and self-sufficient in adulthood, and other 20 to 30% of individuals able to function with occasional support. With age, most individuals show improvement in social communication and self-help skills. So always remember, as pediatrician, 3 A's of autism: assess regularly, appropriate early intervention, and avoid harm. So thank you very much. Now over to you, Shilpa.
Thank you, Neha ma'am. That was a very comprehensive talk about ASD. You started from diagnosis, from the science, early science till the treatment. So thank you so much, ma'am. Next, we will have Dr. Sandeep Kawade, sir. Sir, can you please share your presentation?
Is my screen visible?
Yes, sir.
So, thank you very much, IIP Raigad and AHA Raigad, and all the office bearers of the esteemed institute for giving me the opportunity. I thank all the seniors, Dr. Kangulia sir, Srinivasan sir, for the opportunity. Neha Singh ma'am has made my job very difficult because she has nearly covered all aspects of autism. But I'll try to add on to what she has told without repeating the same points again. So what we have to understand is autism as a problem we all are noticing. But even our medical fraternity does not know exactly how to classify it and how to help these kids completely. So this is an evolving subject. We all are learning with each new patient. We are getting new insights. So this is a evolving. So we have to keep on updating because there are no set protocols as yet. There are two reasons for this. First is the etiopathogen is everything is not yet completely clear. And second, we don't know how to classify this autism exactly. So we don't know how which child to label what. We are getting better at it. And therefore, you will see, unlike other diseases, we are getting newer definitions and newer classifications each year. So DSM-5 has updated the DSM-4 by many ways. Madam has already discussed. But what we have to realize is, first is deficits in social communication and interaction. And second is the restricted and repetitive behaviors. DSM-5 has given beautiful, simple tools for us to help us diagnose. What we must understand that not all behaviors would be present initially, they gradually evolve depending on the child's overall IQ, child's other issues. Some children are easier to pick up early. Some children are very difficult, especially those who have a normal IQ and whose parents put a lot of efforts initially when they realize there is some issue. Many parents nowadays read about it, start to work on their kids. Sometimes it may happen that you may have a child with very good eye contact, but he's showing other features. And in our busy OPD, it becomes difficult to diagnose them. So we must realize autism is just not one or two signs, but a pattern of behaviors, especially in social communication domain with restrictive and repetitive behaviors. This child is suddenly won't present. So there will be some clues from initially. Now they are trying to know how early we can diagnose autism, and there are some evidences in children who are doing experts who are doing the general motor scale, Preston's general motor scale in toddlers for early stimulation. They have noticed some pattern, and they have say that there is some predictive value in the motor scale where they can predict autism, but that is not yet true. So there may be some patterns of behavior which are apparent even early neonatal, but very difficult to completely label or diagnose. But if you take retrospective history, you will find certain patterns. So symptoms must be present from early childhood. They must impair because many of us have some quirks. Everybody has some repetitive habits. So doesn't mean that the child will fall in unless it is impairing his daily functioning, either social, occupational, or academic. We may not label it as autism. Third thing, many children with other problems who are severe preterms who are having some disability alone. Both may co-occur or both may be individually present. Sometimes they may overlap. So because of this, classification, it becomes tricky. What has changed over DSM-4 is that now we don't have number of diseases. So now there is no Asperger's, there is no pervasive disorder, developmental disorder, not otherwise specified. So now we know that there is a complete overlap. Some children which we think of Asperger can have autism. There is no clear-cut line demarcating one from the other. So we now consider it as a complete spectrum. Sensory issues are important part. So it won't happen that the child is having only one social communication issues, but other behaviors or sensory issues are absolutely not there. If you dig deeper, there will be some of the other sensory issues. And what they now have introduced is the classification according to the severity levels. So these are the three major things they have changed with the diagnosis. This severity level is useful for planning his treatment, knowing the support, and knowing where the child can fit. That can help. This severity level helps us. Simple way, level 1 requires some support, level 2 substantial support, and very substantial support. What does this mean? If we see in these two domains, in social communication, he can able to speak in sentences. So the child will communicate. But if we go into the conversation, he may find it difficult for, like we heard, he may find it difficult for sarcasm. He may not know the nuances. He may not understand the metaphors. So there will be difficulty. But overall, this child can communicate. In level 2, there will be marked deficits and the communication it will be restricted, but there will be some, at least with the known people, so with family members, he can do social interaction. And level 3 will be severe deficits and maybe non-verbal. And we may have to find ways other than verbal communication for the child to communicate with others. Repetitive behaviors, similarly, in repetitive behaviors, there is some inflexibility. But if you change the routine, he will have discomfort, but he may adjust. Whereas level 2, the rigidity is obvious and it interferes. So there is some shift in the way of the food which is being given. Even the plate is changed. Sometimes he is unable to eat. So that is affecting his functioning. And third is level 3 is extreme distress. Any pattern of behavioral change, the child will see is adjusted well to the surrounding. The school year changes, he go to the new class, there is a new teacher, and the child is absolutely not able to adjust. Again, as this is a spectrum disorder, we have to understand all children are not at the same level. So it may happen that one autistic child may be level 1 in social communication, but level 2 in repetitive behaviors. That levels of support may be different at both the scale, and they have to be individually judged and supported. Second thing, which has been noticed and seen, that the rate of autism is increasing everywhere. Especially in European and Western countries, the rate has tremendously increased where they are documenting. So in 2004, it was 1 in 166 in USA. Now it is 1 in 54. Even in India, you will see, we are measuring it less, but even in our society, the numbers are increasing. So this is quite tricky. In India, some studies have pointed it to 1 in 100, some in 165, 1 in 450. Same different studies at different level. The problem is there is no universal one tool which is applied. Then the screening levels become different. The socioeconomic levels become different. In which children it is applied becomes different. So we do not have a perfect scale, but what we can say is somewhere around 1 to 2 per 100. We are measuring 1.5 children per 100. And that is a very big population. In our OPDs, we are looking at senior pediatricians are there who look at 150 patients per day. So even if we say that they are looking at 200 new patients per week, they must be seeing 2 or 3 autism cases per week. which is hardly being seen by any of us. So we are missing them. We have to work on our skills so that we find them early. Prevalence in boys is about 4 times of girls. Now, this issue is documented correctly, but even in the autistic, the consultant community, it is being seen and discussed that we are missing autism in girls because they present slightly differently and in a slightly different severity than boys. So we are missing autistic girls. So what is happening to you? Why is autism numbers increasing? Most obvious way is we have better screening and identification. We are looking for autism. We have advanced tools which can help us to find even the subtle cases. We are changing the definition. Therefore, there is increased training of healthcare professionals. We are making the definitions more simplified, and therefore, we are able to identify autism early and in more children. This is the most common cause. Other causes which are worrying is maybe the pollution, the climate change is affecting maternal stress, prematurity. We are saving more premature babies. We are saving more low birth weight babies, and therefore their numbers are increasing. Our society, even Indian society, the parental age is increasing. Now the marriage age itself is in the late 20s, and mother parenthood comes around late 20s or early 30s for most, some even later. So this may be causing a problem. We don't know whether it is a true increase or better detection, and research is ongoing. And like many of the puzzles about autism, increasing numbers is a puzzle which has yet to be solved satisfactorily. Again, the etiology. We know that certain MRI patterns are associated. We know that certain genetic changes are associated. But we don't find a complete 1:1 association. So this must, and this is seen because of the spectral diversity, that this is a wide ranging group. There is some disrupted neural connectivity by genetic variations, abnormal information processing in the brain, which affect the fundamental skills like facial recognition is a problem, which can occur due to any brain trauma before multiple factors are affecting autism. Some genetic predisposition is seen. Consanguinity, we see there is increase in numbers. So genetic basis is there. But along with that, parental factors, perinatal factors leading to epigenetic modification due to environment must be playing some of the other part, which is causing the increase in numbers as well as explaining the non. There is no 1:1 association with any one factor. And that is what we know yet. Only as research goes ahead, we'll be knowing our answers better. When we speak of etiology of autism, this is one worry for everybody. This is something which has been discussed. Now, with the change in government in USA, we do not know what official statement they are going to bring. But research yet has shown that no vaccine causes autism. It has no relationship. MMR vaccine is no relationship. WHO has done multiple studies. And this claim also originated from a discredited paper which was retracted. But the vaccination deniers will be having their say. And we as pediatricians have to be careful so that our children do not meet vaccines due to this fear. Also, there will be many symptoms which will not be in DSM-5 criteria, diagnostic criteria, but which we have to know. So less than 6 years, there will be disordered and delay in comprehension. So he may know the word or sentence, but he may not understand the meaning. They can mimic poems. So there are some kids in our center who can know 20, 30, 40 rhymes, he can say. But ask him a simple question and he will struggle to answer. So expression, communication, and interaction, that is a problem. But living with the mobile phone and he will learn those rhymes. He will be speaking as a uneducated parent's kid keeps on watching mobile and is speaking in Peppa Pig's accent, English accent. But he won't be able to speak and ask mother for verbally for any need. A typical language development. More than 6 years, Sometimes they pick up the language, but there will be disordered sentences, morphology, the syntax, that is, the meaning behind the word may not be there. And also, what is known is, like Madam has also discussed, some motor delays. If you go and find history, there is history of slightly delayed walking, slightly delayed. So there is mild hypotonia, deficits in coordination, movement preparation. So if you go back and look at these autistic children, even the better ones will have some of the other problems in these fields. So we have to look for symptoms in DSM-5 criteria, but along with this, other patterns also. Screening, what is the latest guidelines for screening? AP has recommended universal developmental. So they have a guideline at 9 months, 18 months, 30 months has to be done. Out of which this two, the 18 and 24 months, they have a checklist for autism. They have other also age and stages questionnaires covers autism, and screening tool for autism is also done. But MChat is the most commonly done screening tool. Other than this, if any parent comes to you and expresses concern about any of the speech, social skill, and behaviors, take back, think, and again observe the child, because many times, many we have seen, pediatrician itself, it's just 18 months, he will speak, give him time, and we miss the golden opportunity. We know that we don't want to worry the parents, and many of these kids cover on later. But in doing so, we are missing those few cases of autism which could be diagnosed early. So if your parent has any concern, please look into the child again. Second thing, you looked at a child at 9 months, you did not find any maybe symptom, or there may be mild things which we did not consider at that time. But we have to keep on going, because depending on the developmental stage, the symptoms may develop later also. So red flags, if there is lack of response to name, absence of gestures, poor social engagement, or sometimes there are some kids, toddlers also, when they come to the OPD, they're crying continuously and they cannot be consoled. So even when we are not examining, they are continuously crying in the OPD. And that may happen at the stranger anxiety phase, 9 months, 15 months. But sometimes this is going on. So even that symptom, we have to be worried, because the child is not following a pattern. So children are worried when we are examining, but they go to the mother, they become silent. But a continuously irritable child on multiple visits, even that can be a worrying sign. And we have to keep an ongoing surveillance until completely developmental concerns. If there is any minor concern, just keep a watch on this child. If screening is positive or any concern is there, better to refer to a developmental specialist early. Depending on the area you are, there may be a neurologist, a psychologist, or a developmental pediatrician, ideally, who looks at the child and then screens or tries a diagnostic test. Even when there may not be a specific diagnostic test which is positive, but there are certain delayed signs, there is no harm in starting intervention early. It may be speech, it may be OT, it may be behavioral therapy, sensory integration. Better to start it and then stop it when the child is normal development, having our normal developmental concerns are passed on, other than waiting and starting it late when the child shows multiple symptoms. So do not adopt a wait and watch approach. Early intervention is good. So ma'am has discussed in detail MChat. So this is the ideal screening tool. 20 questions, just yes or no. Parents can fill. 0 to 2 low risk, no action needed. But medium risk or high risk, referral, follow up with the child. Sometimes if the parent is not willing immediately, just next 2 or 3 visits, just keep telling them, keep watch for the symptoms at home, do this. So when they start to watch the symptoms, next visit the parent says, yes, we are observing this, and then we can send them to a developmental pediatrician. Because many times just one thing and the parents may not go to a developmental pediatrician. If we keep on communicating, they will. Using a MChat tool is easy, and we can do it in our OPD easy. So let us screen early, even if sometimes few of these cases will be false positive. Because missing a case will be more problematic than giving some speech therapy to a child who may not require. Then when the child goes to a developmental pediatrician, they do many tests. ADOS-2 is the standardized test, which is done even at as young as 12 months, and it's computer diagnostic test assessment, which is accepted worldwide. CARS. So these are the two tests which we do in our center, ADOS and CARS. And they not only give us diagnosis, they give us the domains of problem and can help us to monitor and follow up the child with. Then Indian tools are also there, INCLAIN and ISA, which are free of cost, and many developmental pediatricians use them. There are minor advantages, disadvantages one over the other, but ideally, it is better to get at least some of it done so that we get the level and we start the intervention. This doing a specific test should not be a barrier for a child to start therapy if you are suspecting screening tool positive and you don't have a diagnostic tell, there is no harm in giving speech therapy or starting intervention for some issues which the child is having. As I discussed, many consultants are now observing that girls are not must not be having that low a risk as 1:4 times as boys. And because many girls have been seen shown symptoms later on also. So what are those why these girls are missed? Because girls are good at masking and imitating. They want to fit in, study, to copy others. So the mimicking actions are done early, so they do not be picked up early. So girls, usually females, are socially motivated to seek friendships. So even though it becomes difficult for them, they find a way to make a group, at least a small group. They don't have temper issues as much as boys, and therefore they suppress the emotions, and therefore they are not picked up early. More key feature with autism is anxiety. So they have severe anxiety issues, and they also have typical repetitive behaviors like, but they are usually aligned. So they keep on keeping not noticed. But other patterns in boys are noticed early. So that is why probably we are missing them. Also in girls, what difference is seen is their pitch. Language differences are there. So they have an unusual pitch intensity, speak very rapidly. Social differences. So mimicking behavior is there, but they do not have a deep social understanding. They have interest as like age appropriate interest, but it will be very intense in that particular domain. And they are many times hypersensitive to sounds and textures. So there may be few girls who absolutely are unable to wear cloth tags. So their clothes have tags, they will not wear it at all. They won't wear certain texture no matter what. That is so discomforting for them. It is difficult for them to express openly, but they will resist it. Autism in girls has unique presentation. As we go ahead, we'll maybe understand it more. But we have to know that girls also have autism. They'll be slightly different, and they will also require some help. What are the barriers for identifying a risk? So why are we not picking as pediatricians as a group? Why are we missing them? One, the children of autism sometimes maybe average or even above average intelligence. So we see that the child is performing so well in certain domains. So we say he's slightly quirky. And we don't understand that simple social demands of a younger age, they may cope up. But as they go higher classes, higher places, they have a problem. Gender differences we discussed. Coexisting conditions. Sometimes a child with ASD can have associated ADHD also, or ADHD child will focus, the parents also will focus on disruptive behavior and may miss the social communication behavior problems. Barriers in screening and referrals. So many times, even now, we keep on going to a general practitioner who is not at all trained or doesn't even know. So we conduct courses for or sessions, workshops for even general practitioners because many times they are following up the child and they do not have any clue regarding this. And the most common advice they give for any speech delay, "Yacha kaka ushira bolla hota ha bole." If uncle spoke late, so probably he'll speak late. Don't worry, wait for 5 years. So that is advice given even today by many doctors, and therefore it is a challenge for us. Socioeconomic and cultural barriers are there. So even though screening accuracy tests are equally effective for race, ethnicity, or social classes, language barriers. So we may not have perfect scales for different languages. So these are parent answer questions. When these parent answer questions are given to low socioeconomic or low educational background, we may not get the correct answer. Cultural differences are there. Even parent questionnaire, some parents don't want. So educated parents, they give voluntarily wrong answers because we do the diagnostic test. The child is coming in moderate to severe autism, but you ask the parent, they'll be saying there is somewhere a trust deficit where they fear the labeling. They fear that the child will be orchestrated, and this is causing a problem. So there is some need for an linguistically and culturally inclusive tools which can be applied across populations like ours, which has so many languages, so many socioeconomic and other variables. One thing which I would like to say is something which caught a lot of noise, especially during the pandemic, virtual autism, where because of everybody of us was glued to the screen, and there were infants and toddlers, young children having internet for 8, 10, 10, 12, 12 hours. That is what was happening. It definitely negatively impacted the language and social development. But what we have to know is just excessive screen does not directly cause autism. Then why are screens usually blamed? What happens is autistic children, they have certain fixed preferences to sensory stimuli. So in a screen also, they find what they like and keep on and repeatedly watch it. Autistic children, for them to self-regulate, start going towards screen. And even their parents start to provide the screen because that is the only way for it to make the child sit and eat many times. So a TV watching child, instead of just blaming the parent, we have to see why is the screen needed. If the screen is needed, is the child having a problem? Instead of just blaming it. There is no such defined term as virtual autism that we have to tell. Because once the parent gets this term, they think that my child is having a problem due to mobile. I will remove the mobile and my child will be normal. That we have to tell. Autism and screen time are different. We have to reduce screen time, but we have to understand the problem of the child is due to other thing, and we may require intervention and therapy and just not label somebody is having virtual autism. We also have to be careful that do not rule out autism only because there is some eye contact and smiling. Because child mimics, he may give eye contact, especially to the regular caretakers, and even show affection to them. But that is not a sign that it is not autism. The child has to understand what this smile or this means and has to repeat with other social situations also, and that too consistently. Then we can. But just child giving eye contact or smiling doesn't mean that he's not having autism. If the parents tell that he is having pretend play or just normal early language milestone, it does not completely rule out autism, especially in gifted children. If your difficulties appear to resolve after some therapy, we may need to assess this child later on also because it completely doesn't rule out autism. And sometimes early diagnostic assessment may show no autism, but as we go ahead, especially with gifted children, we may find that they have autistic traits. So just because these things are happening, do not completely rule out. Keep a watch on the child's development, and we may need to alter our diagnosis even later on. So this is a photo which I have given. So this is a quote by Temple Grandin, who is a famous autistic personality who has written many books on autism and is a very strong advocate of autistic care. That the problem with of label of autism is you have a spectrum that ranges from Einstein to someone with no language or mental disability. So this is a 6-year-old. He is such a mathematical genius. He comes to our OPD. His mother used to give him tables. So he started to write 10, 12, 14. So mother gave 4 letters. So by 6 years old, his number was given, and within 1 or 2 minutes, he has written without any mistake, without calculating anywhere, the table of this 6-digit number, and he has written it down. This is how much that 6-year-old could. We have children who have learned Gujarati or some other language just by looking at YouTube. They cannot communicate their needs to their parents. They cannot understand that this is sadness which I feel and communicate to parents. But he can speak good Gujarati movie songs just by repeatedly listening on YouTube. So it is tricky to just label uh, lack having child having good ability as not having autism, because the child may not face problems in this domain. Development, the child may have problems, especially as the child goes ahead. When there is stress, they cannot communicate their pressures, they cannot communicate their needs, and as the situation gets challenging, they get exposed and then require care. So, this is not platform to conclude all the treatment part, but without parental involvement, we cannot help autistic children. Parents are the key people. Motivated, positive parents are the main people who can change the life of the child. We as therapists can only help them and empower them. Educating the parents what is autism, starting early, tailoring our support to the needs of the child and the family. Because every time the family may not be able to come to you for every session, managing their behavior, helping parents with themselves living a fulfilling life, creating a sensory friendly environment which helps the child and parent both to be calm, enhancing communication with the parents and even communication between the couple so that they can take care of the child better, and giving them goals to not just make this child verbal but helping this child become productive and optimizing his situation. So parental involvement is the key, and if you can motivate that parent to parent group, to other uh, uh, platforms, through podcasts, to connect, will be the biggest help which autistic child can get. There are many books we have written by autistic parents. Many of the research has been done by autistic parents, and you may find many success stories of autistic children where parents have done miracles and the child has improved. And this motivates our parents to keep on doing, and the tunnel seems without light. So having parents as allies is the most important thing which a therapist can do to improve the outcome. Many of these parents have very common myth that autism is due to bad parenting. We have to remove this guilt. Your parenting, like any other parent, can improve, but you are not the cause of it. Many times the blame game starts between the parents. We have to stop it because both of them are needed for the child to progress. Many times there is a thing that the child will outgrow it. We have to tell it autism doesn't get cured. There will be a time when the many children will be able to manage their problems through different routes, but there are even adult autistics who sometimes require help, even though they may be doing very well in their careers, in their other domains. For certain issues, they will require help, especially in relationship problems. There is a common myth that autistic children don't feel emotions. No, autistic children may sometimes feel more intense emotions, but are unable to express them in ways that which we will understand. ADHD or autism is just laziness and lack of discipline. No, it is a problem which can be tackled. Sometimes parents think that maybe some miraculous medicine may help. And when we are not giving that medicine, they go to either out of the way treatments or even some rituals. That we have to stop, because this unnecessarily many times has caused big problems, like people doing stem cell therapy for autism. So that has to stop. Also, keeping on wasting time on such miracle cures, it delays the good treatment which the child requires. Neurodivergent children can't succeed in life is the biggest fear the parent has, and that we have to expel by giving examples, by showing uh, other parents who have successfully navigated this. So in our center, we do every year in autism celebration. This year we are doing on the Saturday 5th, where parents come together and they share their success stories. And because of it, the newer diagnosed parents get motivated. So can we do that? And their biggest fear is somebody calling my child autism means they are labeling my child as mental retarded or some labeling which will cause my child great harm. So we have to tell them this is not a label which is put on the child. This is something which helps us understand the child and help the child better. It will help us optimize the care. This is not a label which they have to share with anybody if they are not comfortable. This is something which will help them help their children better. These are the common myths which we have to break in our parents and make parents alive for better management. There will be developmental pediatricians who will be doing the rest of the care. But these parents, when they come to us, require the support and appreciation for dealing with such issues day in and day out. So remember, the man autistic child comes in our OPD, he's having sensory issues, crying inconsolably. Sometimes we get irritated. Just imagine the parent doing this 24/7. You have to appreciate them, give them support, and once they start to see improvement in their child, will become the biggest ally, and that child will have somebody who will make the greatest progress. So thank you for this opportunity. Every child is gifted in some way or the other. We just have to find ways to unwrap that gift. Thank you.
Thank you, sir. You that was a very you described it very well, and yes, you clearly mentioned the children who we should not miss and the small things that we need to see uh, for diagnosis. We have one more speaker to go. Without any delay, I would request Ms. Gopika to please share her slides.
Is my screen visible?
Yes, you're audible.
All right, great. Everyone, thank you so much for joining. I also want to thank Dr. Sandeep for segueing, for making an amazing presentation. I'm going to build on what Dr. Sandeep said. Thank you, Dr. Vikas, for inviting me on this esteemed platform. I feel really grateful and I feel really empowered in presence of a lot of professionals right now. So I'll be talking about autism spectrum, sensory and scholastic systems of support. That is how to support students in how to support students with their sensory needs and also with their academic needs. All right. Again, just for introducing, my name is Gopika and I'm a remedial educator and a learning specialist. All right. So in my presentation, I'll try to be as brief as possible. I'll be addressing what are the early signs. I won't touch much on it, but as the previous presentations have done really well, but I'll just touch very briefly on early signs and autism as a spectrum. Then I'll be talking about what are the tools and assessments that I used. Third is what is the importance of support? Why is it so important to support students on the autism spectrum or students with autism in school setups? And fourthly, I'll be talking very specifically on what are their needs and how do we support them in a school setup. All right. In my presentation today, I'll be using person first language, which is students on the spectrum or students with autism rather than autistic students. All right. So first, I'll just begin with early signs and autism as a spectrum. We already touched upon what is the importance of finding out or identifying the early signs of autism. You all spoke from a pediatric perspective and also on what parents should look out for. identifying early signs and traits of autism is really important, as it creates a structure and also gives a segue and into assessment, into providing support in schools, and proactively realizing, hey, how can we support this student better? Next, I'd like to talk about autism as a spectrum, and it's not a binary. This mindset is very, very important, especially in a school setup or and otherwise as well. Rather than labeling someone as less autistic, more autistic, high functioning, low functioning, it's using the term support needs or using the term requiring support is an excellent way of helping the student, as it is empathetic, and we're not labeling them, but we're also being very realistic about what they need help with and how we can help with. So for example, it would mean this student has support needs, this student needs support with their sensory needs, this student requires support with their communication. So what happens is we're very specific with the way that we are working with. All right. Next, I'll be very briefly touching on the tools and assessment and why we need to do them. Now, 1 second. I'll just open these up. So, assessments and observations guide us on domains and aspects that a student needs support with. Now, these are assessments that professionals use and also provide information to parents as well. This is not definitive. It is not restrictive, but it gives us guidelines of, oh, does this student require help with their communication or with sensory aspects, or is it communication or regulation and all of those. So this kind of gives us a structure of where to go. All right. Next is the importance of support. Why is it so important to support students on the spectrum in school? They're being supported, they're being helped in a therapeutic setup when they go to OPDs with the doctor as well, they're being supported at home. Why is it so important to support them in school as well? So first, I'll be talking about what are the challenges that students or individuals on the spectrum struggle with, and also what the family and community around them struggle with. So one is societal stigma and exclusion. As spoken by Dr. Sandeep previously, there's a lot of myths, there's a lot of misinformation that goes around. This is either due to ignorance or it is due to bias and discrimination, but it is very apparent, and this creates a challenge in students asking for help. This creates a challenge in parents asking for help, or in teachers providing the extra amount or the additional support. One really big challenge is caregiver strain and parental stressors. As Sir said, motivated parents and positive parents. So it needs to be 2 in 1. And a lot of times parents are at wits end. They do not have the resources, or they don't have the information, or they do not have the time to process and work through all of this. So that is a really big challenge. Environmental and systemic unpredictability. Now, this is for students on the spectrum. School environments are very unpredictable. They change every day. No school day looks the same that the previous day is. And systems also, like there's various moving parts. There's in schools, there's assessments happening. There's a lot of movement that's happening. There's also socio-emotional aspects and academic aspects. There's multiple things, and things can get unpredictable for the student on the spectrum, and this can get very difficult for them. So that is a challenge. And lastly is institutional barriers and resource gaps. So these are macro, on a very big picture level, what are challenges that are faced. This could mean lack of research, lack of resources, lack of infrastructure. And for a school setup, it would mean lack of training. Teachers aren't trained how to work better with students. Parents also are having lack of information. So these are challenges that autistic individuals and the community that works with them face. Now we'll go on to then why is it so important? What should schools do here? So the 3 points. One is to create a safe and supportive space to promote student success and growth. to facilitate socio-emotional development and functioning. So this is why is it important to support the needs of students with autism. So now I'll be touching on to the specific needs that were covered in the previous conversations on how are these needs supported in a school setup. So I've put it under the umbrella of socio-emotional skills, behavioral support, sensory processing, activities of daily living and life skills, and academic support. Now I'll be going further into the details of this. All right. So socio-emotional and behavioral skills, something that was brought up in the beginning of the presentation was they're not able to understand the social language or social manners. They find it difficult to understand sarcasm or um, the nuances of social conversation. So how to help with that? Provide clear instructions and explicit instructions with what is the rule. Guide them. Help them understand what they are expected to do. With regards to what are they expected to do, identify positive and negative choices. Tell them that when this is a positive choice, this is a good choice, this is a bad choice. This also helps with labeling the behavior. A behavior will be problematic. A student is never problematic. A behavior is having a negative consequence. The student is not negative. So identify this with the people that you're working with, and also help the student identify that, hey, what you did here was a bad choice, or hey, what you did here, let's make it better. The next aspect is support emotional regulation. Emotions can be really intense while working in a school setup. Help them identify their emotions. Help them identify what am I feeling? Why am I feeling this? This also goes in touch with their sensory needs. They also are aware that they have sensory needs, but often we need to bridge that for them as adults and tell them, hey, I understand that the sounds are very loud for you. Let's get you out from here. Is this feeling better? So an example of how helping them with their emotions while also addressing their sensory needs comes in touch. Addressing internalized and externalized behaviors. Now, internalized behaviors would show up as anxiety, fear, isolation, or not communicating. Externalized behaviors would be, defiance, meltdowns, retaliation, violence, and other behaviors as well. Both of these are really important. It's not both addressing both of them is really essential, because that's the only way you can support a student to show success, to show growth, when you're addressing what is their emotional state. To help them with social interactions, use stories, use visual aids, help for a more concrete example, make it as a play, make it as a role play, something that they're witnessing. Oh, if one person says this, what am I supposed to respond? Give them that script. Help them understand step by step what they're supposed to do, and that actually helps them in social interactions. Most importantly and lastly, foster skill building, peer connections, and personal growth through interest and reinforcement. Help them feel motivated to come to school and work on their skills, their interests, something that they're good at, and create a peer support system for them, because we know that social interactions might be difficult. Create that group. Be like, hey, this is your friend, and tell that friend as well, hey, this person's going to sit with you. Come, let's do something together. So be that proactive support. Now I'll be going on to sensory processing, how to support sensory needs in a school setup. Firstly, begin with identifying a sensory profile, creating a whole sensory profile. This happens in collaboration with the developmental pediatricians and the therapists and the parents, and realizing, okay, this is what the student requires and this is what the school has. Now, how can we bridge both of them and make the situation best for the student? Address overstimulation. Address what is making the student feel very hyper. What is something that makes the student feel very sleepy or very low energy? What is something that triggers them? What is something that they love? Create a sensory profile. And that's when you're actually able to address and facilitate the student's need in a school setup. Incorporate technology. Now, for students who have not developed speech yet or are non-verbal, incorporate technology, use AVAs, use other ways of them communicating, because communication is not always speech and we want them to communicate. Offer choices, tell them what things can be very overwhelming for them, offer them choices. Give them two options and then ask them to choose one. This really helps, especially when they're very overwhelmed or when they're learning something new, or to help them with their peers as well. It's an established fact that students with autism really benefit with visual schedules, visual reminders, and visual guidelines. So use that in a school setup to reduce the unpredictability and the fear or apprehension, like, oh my God, what's going to happen? Help them and put it down in a way that's easy for them to understand. Okay, this is what I'm expected to do. This is what the teacher will do. This is what I am going to do today. So it's really important to establish clear guidelines and expectation on these. I'll just name what are the activities of daily living and life skills that students need to work on. Now, this is not worked on primarily in a school setup, but is very important long term to be addressed by parents, therapists, and community. Self-care and hygiene, expressing and communicating their needs, executive functioning, social skills training, and transition planning. This is something that work is not just in a school setup, but is a skill that the student will exhibit and will require support with throughout their lifespan. The last part is academic support. Now, how do we actually support students in a school setup with their academics? Adapt and modify content and assessment for their individual needs. This means looking at the level of the student, looking at the activity of the student, their cognitive ability, their attention, their sensory needs, and their interests, keeping all 5 of these in mind, and adapting the academic content, the curriculum for them. Also changing assessments. Now, all students will not be able to give a verbal assessment. Looking at their motor skills, some may not be able to give a written assessment. Adapt them, change them, modify them to individual needs. Everything doesn't have to be a structured box. Provide tailored intervention and consistent adult support. This is really essential for early years and additional years as well, as interventions are the space where on a one-on-one individualized setup, the student actually is able to build on the skills that we mentioned previously, like socio-emotional goals or academic goals. That's when you're actually able to work one-on-one with the therapist or with the special educator or with a counselor and actually work on those skills. The last two are ensuring that activities are clear and achievable with accommodations. This is really, really important, as school days can generally already look very difficult for them. They already know that there's going to be a lot of pressure here. But giving them the small success, giving them small steps of like, hey, you did this, I love that you did this, amazing. Small steps, and making them feel, hey, I can do this. So make it clear and achievable for the students so they feel motivated and are reinforced to continue receiving academic support as well. And one last skill is teaching them test taking and organizational skills, as students on the spectrum also currently might have comorbidities with ADHD or specific learning disabilities or intellectual disability, or generally as well, they might struggle with working memory and executive functioning. So this is something that does help them to grasp academic support. And I'd like to end with, none of this is possible without collaboration and planning. So create individualized education plans. This happens in collaboration with the therapists, the doctors, the parents, the teachers, the co-scholastics, as in art, music, dance teachers, yoga teachers, PE teachers, everyone who is involved with the student and everyone who has a stake. Create a profile, create goals that you want the student to achieve that are easy and achievable. Have parent meetings, have feedback. Provide feedback to the parents and also receive feedback on how we can improve as a school. Incorporate strategic structures from speech and occupational therapy, behavioral therapy. A student might receive support externally from other sources. Let's try to integrate and let's try to get on the same page on, okay, this strategy works here. How can I put that in school? Okay, this is the language and instruction that's being used at home. Can we use the same thing here? Oh, the school, we realized that in school, the student is liking this song a lot, and that helps him to motivate to do his work. Can mama use that at home? So incorporating structures from all places to be on the same page with the student, on a macro level and a long-term run, sensitization and awareness in school communities, parent communities, having UDID cards and the government disability aids, as that helps them in higher grades when they are giving assessment, giving exams, having board exams, preparing for college, depending on their needs. So UDID cards also helps them access healthcare, helps them access support to intervention centers or pediatric healthcare as well. So on a whole picture, I feel everything won't seem as impossible and as scary if everyone's collaborating, everyone's on the same page, and everyone is actually open about, okay, this is what we're working with, this is what we're struggling with, this is what I want for my child, this is what I want for my student. How can we come together? That's when problem solving, and that's when actually creating a supportive community for the student is helpful, is when everyone wants to work and do the best. All right, that's all from my end. Thank you so much for this opportunity, and yeah, I'll end here.
Thank you, Gopika. That was a very excellent talk. And you correctly mentioned that it takes a team. It is not an individual person's job, but a teamwork to settle the child or understand the child. Okay, so let's take a few questions. We have a few questions on the chat box. So first question would be, so many a times we get children in the OPD who don't have all the amenities or adequate therapies which are required. So in this case, as a general pediatrician, how can you best handle the patient so that they get the best of it? Dr. Sandeep sir, would you want to take it?
So, as I said, we have found that we get sometimes patients from remote areas. They cannot have therapies on a daily basis, or maybe even not possible. Maybe just once a month it is possible, otherwise not possible. Sometimes cost is a factor. So for cost is a factor, I think there are options like government centers now are there at each district place. In Pune, we have at Aum, so we may get help from there. Second thing, what I find is uh, in educating mother. So even if the mother is not that educated, you can tell her the immediate two problems and just work on that problem during that one session and teach her the tools to cope up only with these two problems over the next month. And many times he is repetition of those same therapeutic technique may not be as accurate as the therapist, but at least in some extent will help the child. If so child is having sensory issues, we give them 8 or 10 things which they can do at the home to give different sensory experience in a comfortable environment so the child gets adapted to that sense. If small things can be done, the child gets help, more help to the parents if it is not possible on daily basis. And as the child progresses, many times the parents start to take more effort. Sometimes because they don't have any way, they try to avoid it. Second thing is, along with education, what we can is club the therapies. So one time the child can come in, the same visit if we can do multiple things and take care of it, so that each day, if parents are working, it may not be possible to come. That can be done. Third is we do some friends consultation. So even if we are paying for 4 sessions, we take them for the whole month. If something like this can be worked out, even uneducated parents help the children to last excellent. This can be done. This can be done.
There is one more question. Developmental education and how much percent of the children become self-independent in adulthood?
Slightly tricky. It depends on multiple factors. One is how earlier we are identifying the IQ of the child. So, an autistic child with intellectual disability will have multiple problems. But same time, with we have seen with good IQ or even excellent IQ people, they start to cope up. So if coping up is just having a good job or having good education, we will see many children can do that. With support in a good inclusive school environment, these numbers can increase. But instead of focusing on the percentage, because we have just started to identify autistic, and starting to help them, we must try to help each child to the full potential because we never know what the ceiling for this child is.
That's right. Vikas, sir, you want to ask something?
Yeah, very interesting discussion going on from all aspects and quite interesting. So what I have observed in these cases is sometimes some kids excel in some areas but struggle in others. For example, some kids have autistic kids have very strong memory but have a difficulty with the abstract thinking. So like sometimes the traditional teaching methods may not always be effective. So is it that the individual instruction is often needed and on both aspects, like from a development perspective and from a special educator perspective, what are the challenges in such cases?
Can I take this up?
Yes, ma'am. Continue.
So, especially while working with students on the spectrum, we will often see that they are excelling in a certain area and there are certain deficits or there are certain struggles in certain areas. Now, I'll just pick on the example that Dr. Vikas was mentioning. If a student has a really good memory but struggles with abstract thinking and social interaction. So, what does happen is in a school setup, we will combine or we will use the strength they have a good if the strength is they have a good memory, they have a good retention, we kind of use that as a foundation to then have building blocks of abstract thinking, but that is also we have to modify it to the students level. We have to see what is realistic for them given their cognition, given their attention, and given their social ability as well. So there are multiple factors into this and you have to take it very one step at a time. Yeah, that's all.
Just I will add, ma'am has told
Yes.
correctly. What we have to do is many times, even the therapist who is working on a child doesn't know what exactly will work next. Assessment. So what happens is 2 months, 6 months down the line, we again reassess the child as a team. Developmental pediatrician will be there, the occupational therapist, maybe the speech therapist, sensory person may be there, and along with the parents. And then they discuss what were the goals which we had set and whether we achieved them, and are there any lacunae previously, and what are the expectations next. And if there is a changing situation, so let's say the child was in playgroup and going to the new school now, what are the challenges he's going to face? And if we start to work on that, techniques will work in some kids. There is no one approach fits all. So it has to be an individualized plan. And people working consistently may find ways that sometimes it happens that the mother or father suggests something which helps more than what the therapist is. So we have to individualize the plan, make a synergy, and on places we are struggling. Sometimes it happens that 10 things go smoothly and 11th everybody stops. And there we may have to try different ways. So there are different ways of ABA. There are different, maybe sometimes we have to step down and lower our expectations and give the child to catch up, time to catch up. And that time is the only answer. So there will be not a single answer. It will be individualized. And that is the, I think that's the beauty or difficulty of autism, where you have to work with the family and the kid to understand the nuances because he will act differently.
One more question to sir. That sometimes yesterday a child was autistic Down syndrome baby with a 16-year-old adolescent Down syndrome baby recently diagnosed with some autism spectrum, and now he is having some sexual feelings and typical adolescent behavior, touching in genital parts. So now the family is facing a dilemma like how to deal in such cases, especially adolescent Downs with autism becomes a more a mixed scenario. So it becomes slightly difficult to deal with such kind of. So how to go about as a general pediatrician, what should be our approach for such kind of cases?
So a child having multiple diagnoses along with a late age, it becomes a problem. So we have to first assess how is the communication level of this child. Physically, he's having symptoms, but what level of understanding he has. So maybe you have to get a psychologist involved. You don't know how what level of understanding or communication IQ this Down syndrome is at. What happens is this becomes very new. As therapists, when we are doing this, when a child is 12 years old and he's starting to have puberty. So Down's girls also we have this multiple problems. When the girl is around 8 to 10, like we do for other girls, we have to start to prepare the family first and then, because this is natural process which are expected. When we have a child, we will follow up Down syndrome or any such thing, start to think about these conditions early and start to intervene. At 16, we will have to involve a developmental psychologist who communicates with the child. Depending on the understanding level and the communication, we have to give him clues of behavior and we'll have to make him understand things and don'ts gradually. It depends on the environment, the monitoring the child has, how communication or the understanding of the parent. The parents may get panic and making the parents also understand to a certain extent this is a natural process because for them it may become matter of sin. Then where the social setting, so it becomes difficult for the child to understand the social setting which is appropriate or inappropriate. Simple things, this is a big thing, sexual changes at 16. But even before that, when the child is 13, 14, what kind of clothes to wear? They may have a comfort at a different age, but when they are 13, 14, that may not be comfortable around. Especially as the girls are growing, boys are growing. The way they sit, the type of tone they use, and the mothers start to panic. Now she's having period, but she's not able to tell, or she's not able to understand when strangers are speaking to her. We have to work early to avoid problems later on. And at the later the age and multiple diagnosis, a very difficult challenge for everybody to manage.
I would want to add a little bit. So the diagnosis of autism, maybe it is something which was missed initially because it does not come suddenly at an adolescent age. It is because of the intellectual disability or some kind of because with a Down's child, it uh, got mislooked, did not, it was not paid attention to. And so now, as the child has growing and as the pediatricians, everyone is more and more aware of the autism diagnosis, we are trying to understand that this can be a autism spectrum disorder which is co-occurring with the Down syndrome. Like we all already spoke during the Downs Day also, that teaching children social skills, good touch, bad touch, would come from a very early age. It should be started for each and every child. It should be started from a very early stage. The moment they start communicating, we have to make boundaries so that they learn how things are supposed to be. Yeah. Gopika ma'am, there is one question for you. Can you explain how transition planning is to be done and how to have a family-centric care?
Sure. So, question number one about what is transition planning. Now, transition planning, there are like two, three different aspects. One is transition in a school setup for students who have never been in a school setup before. For the first time, they're coming in a whole group. Now, they require one-on-one attention. They're used to having an adult with them. Now they're going to sit with like 15 to 20 to 30 people. So it's a big transition. Transition definition wise means a big change where there's multiple aspects that's involved, but transition basically means big change. When there's a big change in the environment of the child, in the way that their routine looks like, and in the way that what their expectations are. Those are three big transitions that generally students might struggle with. So planning them, telling them, preempting them, telling them, hey, this is going to look differently. This is going to, we're going to do this differently. We're going to have planning them, telling them, like as Sir mentioned the previous question about adolescence and puberty, telling them when they turn age 10, tell them we're going to turn 10 years old now. When we were smaller, did you notice our body is growing? We're becoming taller. We're having telling them as well, decreasing the unpredictability that they have, helping them to transition so that they also know ki, oh, acha, ye ho raha. So that is one aspect of transition. Another aspect of transition comes in terms of when a student has inflexibility or rigidity, or there's like a very one track mind about like, oh, this is so. When inflexibility shows up in behaviors, um, to support it, we need to help them with transitions. What happens is that they might want to stick to what they like. They'll have like very specific interests, like I need to do this, I want to do this, I want to do just this. What happens is, in so at home it is okay, we can work with it, but then in social setups, in school setups, working on that flexibility is something that we need to do. So helping them transition from a prefer something that they like to do to something that they don't like to do. Like for example, if someone loves to do dance and music, after a dance and music, if they have to go and sit for a math class for 30 minutes, it is going to be very difficult for them. To help them to transition from that, help them to transition, and also in otherwise also helping them transition from one grade to the another grade, helping them transition, just any change that you are going to provide in the child's environment or in the expectation. Now when someone is going from a different grade, there's also changes in the way that you're expecting them. Someone in senior kg, the expectations that you have are very different. The expectations that you have for a grade 2 student or a grade 1 student, there's a change in what you're expecting them to do. It is cognitively very overwhelming for them. Help break it down and tell them that hey, this is going to happen, and that at that point it's very very important to validate the emotions. Tell them, I understand, I know this is very difficult for you, I will help you while we do it, but we have to do this. Like for example, transitioning for, and this means for younger students as well, helping them transition from, no, you're not going to sit on mama's godi now, you have to sit down on the floor, let's start eating food, let's start eating our tiffin on our own, things like that. So just helping them, planning for them, and also telling them that this change is going to happen and how to help them with it. That was I hope I have given like enough examples of what it means by transition planning. And the second question was how to implement family care. This is a very vague and very broad question, because family care means different things for different people, because the autism spectrum is different. The way that the individual is experiencing and perceiving life is very different to the parents working with them as well. So family care would mean different things for different people. For someone who is coming from a for them family for some people, family care would mean giving them aid, giving them money to actually access medical and therapeutic support. For other people, family care would mean helping them plan out and helping uh, doing parent counseling, helping them address what are their anxieties, helping them talk about it was parenting is going to be unpredictable for them as well. Doing so family care could mean different things for different people, and I can't give a broad answer, but it could be anywhere on the aspects of emotional support, physical support. For some families, it would mean, hey, let's change our house to make it more sensory friendly or make it wheelchair friendly. It looks different for each family, and that's how family care kind of does mean. To make decisions about family care, involve therapists, involve your doctors, involve other family members. For example, if there is one sibling who is on the spectrum and the other is not, they will also, children are small, children will be like, how, what does this mean, why is mama spending so much time with him? So involving everyone in decision making with the family to support the child and also support each other. So I think that is what planning family centric care would sound like. Um, Dr. Sandeep, do you want to take up parent roles and family roles?
Yes, I wanted to add to the transitions one. Madam
Yeah.
explained the transition part excellent. But there are other kind of transitions which are unpredictable. So
Yes.
sometimes there is a illness in the family, or maybe we had a situation like COVID. Sometimes there is stuff in the family. Even sudden change, therapist transfers from one center to another. He has to face another therapist.
Yeah.
This becomes very challenging for few kids. This also has to be managed very carefully This is a big challenge even for adults when such life events happen. And we have seen well-adjusted children suddenly deteriorate, and we have to put a lot of effort to bring them on to par. So transitions are predictable, like changing a school year, but there may be unpredictable transitions also. So
Yes.
that as a therapist, the team has to take care in account, and if they can plan, if they can, they know something about it, and they can plan it, the better. Like handing over care from one center to another when the child is moving, so that becomes a challenge. So if it can be done in a smoother way, contacting the therapist, giving them clues how this child was handled, giving the note, it helps the other therapist continue the same pattern. So the such things can help in other transitions also.
Agreed. Really, really good point about unpredictability in routine and life. Yeah.
And
Next one,
parents'
adopted
roles,
question. Yeah.
as I said during my talk, a helpful, positive outlook parent would be the best resource autistic or child on spectrum can have, because they start to find ways. Once they know that, see, accepting of the problem, knowing a diagnosis is different, but accepting this is there. So, and acceptance, they move on to the further things. So, how to improve. And gradually they also know the tricks कि they know this ये birthday party के यहाँ पे इसको problem आने वाला है, so they will prepare the child, we have to go to this, and they start to gradually, when we counsel them, that gradually this hand holding also has to decrease. So this time we prepare the child 3 times simulation we did of going for the event. Next time we do for only once. Next time just tell him and see whether he can cope up. So even that they learn, and they have to anticipate and help the child. And even beyond that, child has to learn these symptoms, because at 22 and 24, nobody is going to come and tell him. When there is a change in situation, the child has to understand this is going to be a discomfort for me. The noise is going to be a discomfort. So better carry my noise cancelling earphones. So they have to plan for themselves and not get into problems. So parents, I would say, is one of the most important predictors of success. And extended family helps. In certain situations where both the parents are working, work for the grandmother at home, she can get her involved and get her on board. She becomes the biggest asset. So taking them, educating them, and making them ready for the challenges. If we can do that, that would be the best thing possible.
I think all the questions are well answered. And are there any more questions?
I think we really created a very high quality content to be stayed on YouTube for a
Yeah,
long
Shilpa,
time.
there are no questions. Let's find out.
Okay.
Yeah.
Yeah.
So before wind up, I think I will just thank Dr. Sandeep, Gopika, and Siddharth ji also has joined. That's joined. Thank you for joining. And all senior Dr. Srinivasan sir, Dr. Hemant Gangulia sir, Ingrid madam. Thank you, sir, for your blessing. You are patiently listening to the whole. Can you give us a feedback?
You are
Please,
mute, sir.
please unmute, sir. So please unmute.
All three of them, I already typed. All three of them have done full justice, and of course, and one important point that Dr. Sandeep Kavade has mentioned is the parents or the family itself, there must not be any conflict and then put the blame on somebody. So there should be so much of understanding between the parents themselves to make the children do better. Thank you so much. I enjoyed each and every sentence and word, and all meaningful. Thank you so much for allowing me to be there.
Thank you, sir. Thank you so much. Thank you. Shilpa, you can wind up now.
Okay. So thank you to all the three experts today. It was a really engaging talk, and thank you to Dr. Vikas More sir for giving us the platform and pushing us to do these activities. Thank you, Dr. Sunita Ingle ma'am, Dr. Nilima Bhandarkar ma'am, Dr. Chitra Kulkarni ma'am, Hemant Gangulia sir. Thank you so much for everyone for joining, and Dr. Srinivasan sir for being there today.
Dr. Sandeep sir, thank you so much. And you agreed to join on 11th hour. Thank you so much. It is a It was great to hear to you. And Neha has found you.